Good afternoon, or maybe good morning, everyone. So it's my pleasure to welcome you to our GCA webinar on climate resilient health systems. So first, a quick introduction to GCA. So the Global Center on Adaptation is an international organization based in Rotterdam, working to accelerate action on adapting to climate change. And we partner with governments, development partners, private sectors, and communities to support adaptation solutions both locally and globally. And over the past 5 years, we have in particular helped development partners to integrate adaptation into their programs and design and implement resilient projects. Building on this experience and in close partnership with academic and operational partners, GCA also promotes the application of knowledge to adaptation challenges. So we do this by sharing knowledge, leading research where gaps exist, and driving innovation so that adaptation solutions are practical and impactful. And today's webinar is a great example of GCA's global approach, showcasing our technical work on a health project that we have in Nigeria, exploring the critical intersections between climate adaptation and health through innovative methods developed by our academic partners, and providing, as we're here, a space for discussion ahead of our upcoming third Adaptation Insights report on climate resilient health systems that GCA has developed with Oxford Infrastructure Analytics, Institut de Recherche pour le Développement, Population and Development Center at Université Paris-Cité, and the Heidelberg Institute of Global Health at the University of Heidelberg. So our distinguished guest speakers will dive deeper into these topics, and it's my pleasure to introduce them in the order of their presentations. So Dr. Edwina Mercer, she's a senior program officer at GCA, where she leads health adaptation projects. And her work focuses on improving the health and well-being of worker communities in increasingly harsh environments, as well as strengthening health system adaptation. And she will present the impact of climate change on health systems and the current status of adaptation efforts. Then Dr. Scott Tucker, he's a co-founder and managing director of Oxford Infrastructure Analytics and honorary research associate at the University of Oxford. And he will introduce healthcare system of systems vulnerabilities and discuss targeted adaptation strategies. Then Dr. Gerhard Leppertz, he's an economist and a political scientist with 20 years of experience. He has been intensively working on social health protection and healthcare financing. And at GCA, he serves as senior economist of the Research for Impact unit, working on social resilience and the economics of adaptation. And today, he will focus on sustaining and improving access to healthcare and share the main recommendations from the reports. And then Nitin Nagabatla, she's a senior research fellow and cluster coordinator for the Nature, Climate and Health program at the United Nations University Institute and Comparative Regional Integration Studies. She will share her thoughts on the reports and provide a specific focus for the discussion addressing the topic of mental health and well-being in more details. And I also would like to introduce Katie Momber from the International Coalition for Sustainable Infrastructure, who will be moderating today's session. And a quick technical note. So the commenting function is turned off, but the Q&A function is open. So please do not hesitate to send in any question you have throughout the session, which may be answered towards the end at the Q&A segment of the event. So with that, over to you, Edwina.
Thank you very much, Anne-Laure. Can everybody see my screen?
Yes.
Okay, perfect. Hello, good afternoon, good morning, everybody from wherever you are. I'm going to discuss what the impact of climate change is on health systems and also what the current situation of adaptation is for these systems. So how will climate change impact health? Well, firstly, it will increase the demand for healthcare by increasing global health risks, and this is through acute and direct impacts. So this includes a greater frequency, intensity, and magnitude of natural disasters. And And the World Health Organization predict that this will incur an additional 2.4 billion annually by 2030. Secondly, it will also increase the demand for healthcare through the increased risk through chronic and indirect impacts. So this is through the burden of diseases such as malaria, and also indirect pressures on critical systems. So, for example, a decrease in water availability, food security, poorer air quality, and also heat stress as well. And the World Health Organization also predict an additional 250,000 deaths per year due to these indirect impacts. And of course, with all of these climate stresses, that will increase mental health issues as well, which Nidhi will cover in greater detail in her talk. However, health systems themselves are also vulnerable to climate change. So this is through impacts to the health infrastructure, so hospitals and medical centers, also disrupting medical supply chains. It disrupts accessibility for the patients and also the supporting systems, so digital services, waste management, water and sanitation, and also electricity. And lastly, also workforce availability. And all of these components constitute a functioning health service. And alarmingly, with the high emission scenario, the cross-dependency initiative, they predict that 1 in 12 hospitals could face total or partial shutdown by 2100. And I'm sure you've all seen on the news that the impacts are already evident, sorry. So for example, Hurricane Maria shut down 69 hospitals and left them without electricity or fuel for their generators, so for the backup supplies. And also in 2002, the French heat wave, which resulted in 15,000 deaths due to overwhelmed hospitals. And also the flooding in Pakistan in 2022, which impacted 10% of their health facilities. And lastly, Cyclone Idai in Mozambique, which caused a large amount of their hospitals to be out of action. So the evidence is there that we do need to adapt our health systems. So GCA had screened guidelines, international standards, and also policy frameworks, particularly in Africa. So we were looking at health, national adaptation plans, and whether health is in NDCs as well. And as you can see on the image on the left, health mentioned in NDCs is very kind of sparse. However, this was from 2021, and luckily this has increased. However, we still notice that there are a lot of gaps with health systems. For example, they're largely asset focused and fragmented as well, and primarily focus on health infrastructure, whereas of course, supporting systems, medical supply chains, accessibility and workforce availability are also critical for the health system to function. And with that, I would like to pass on to the next speaker, Scott, to delve into this into more detail. Thank you very much.
Thanks very much, Edwina, and good day, everyone. It's a great pleasure to be here and to be able to present some collaborative work that we've been undertaking with the GCA. I'm sharing my screen now. Please let me know if there's any issues with that. I'll be focusing on a discussion, systems of systems perspective, which we've been developing with the GCA to seek to advance the state-of-the-art knowledge that can underpin future climate risk and adaptation assessments in the area. Now, our motivation here, and this sort of builds on the Edwina's presentation, is that we observe that climate hazards can have really large impacts on healthcare services around the world. And in part, that happens because we see the direct exposure of healthcare assets to hazards. So things like the flooding of the hospital that we see in the picture on the right-hand side. But sometimes these disruptions can emerge due to sort of indirect failures of infrastructure on which the healthcare system depends. Often these can be large magnitude and often unforeseen consequences. Perhaps the Healthcare services rely on transportation for patient access or staff access. Perhaps they rely on electricity for equipment. There are many different kind of failure mechanisms in that regard. But we also see that this climate risk is growing, and it's growing at a rapid rate because of climate change, because of increased demand and provision of healthcare services, but also because of an increased sophistication of healthcare service provision. The electrification of medical equipment, the digitization has reaped huge rewards in terms of healthcare outcomes, but they do in of themselves create new potential points of failure and systemic vulnerabilities that increase the overall risk perspective. And so what I hope to communicate here is that these are very complex systems, both healthcare and the way that they interact with supporting infrastructure, and that for us to try to understand them and to be able to advance them and enhance their resilience, we need systems-based thinking, and that's the methodology that we've approached with the GCA and ourselves within this research. The first has been to understand the healthcare system itself, to try to sort of boil it down into its component parts. Here I'm just giving a few illustrative examples. There are more exhaustive description of this that we have in a forthcoming GCA Insights article, but for the purpose of this presentation, this is a small sample of them. We identify critical assets within the healthcare system, including buildings such as hospitals, health centres, pharmacies, but we also see critical vehicles that provide services as well. So these are kind of where services can be accessed. In vehicles, those include ambulances, they could include mobile clinics. But as part of the healthcare system, we also see essential material provision through the supply chain, where we need buildings like medical storage facilities, warehouses, where we need vehicles like refrigerated trucks to store medicines. But we also need one other input for the healthcare system, and that's, of course, the staff, be they medical staff or other administrative staff. We see physical assets in relation to where they live and stay and how they're transported to deliver the healthcare services. Now, beyond the healthcare system, we see assets that provide these critical services. If I'm to go through those now from different sectors, from energy, for example, we need electricity. We need electricity to power essential equipment to provide lighting. We need liquid fuels for transportation. And indeed, to enable road transportation, we need roads that enable patients to get to these service access points, but also from where the supply chain can be enabled and so on. Other transport subsectors are really important, things like rail, ports and airports, in particular for the supply chain to get equipment, to get medicines into the places at which they're administered to patients. Water is of vital importance at these facilities, and sanitation as well, and wastewater treatment for hygiene purposes, but also, of course, to cater for basic needs. Large volumes of healthcare related waste are produced. Some of it's sort of more general waste, some of it's specialized and hazardous, but it all needs to be managed, of course, to prevent escalation of negative healthcare outcomes. And finally, and of increasing importance, is that we see digital communication and other forms of communication through radio, internet, phones to be vitally important for individual healthcare assets, but also the way in which they're coordinated. Now, I've just described healthcare systems and infrastructure systems, but what a big contribution of this joint research is to be able to understand how they come together and how we can form a generalized understanding of this infrastructure and healthcare system of systems. And on the left-hand side of the screen, you'll see this kind of visual representation that highlights the complexity, highlights the different types of interconnectivity, different types of interdependence that exist between these assets. And what's important here is that this type of representation can then be encoded mathematically into computer models that can do risk analysis and adaptation planning. They enable then to be able to highlight these direct risks, like the flooding of the hospital I highlighted in the first slide, but they also importantly enable us to look beyond the direct risk, to be able to understand and to model how these indirect risks, like for example, between energy and healthcare, and or cascading risks, like as demonstrated here between energy, transportation, and healthcare, how all of these different forms of risk, often that are unforeseen, can be understood, can be modeled and quantitatively estimated. Now, the reason we do this, of course, is to understand different sources of risk, but it's also about more accurate risk estimation. In economic terms, this allows us to not only understand damages, but other kinds of losses that can emerge. Now, that's really important for adaptation if we're seeking to justify adaptation financing, adaptation investment. We need to be able to communicate the benefits of adaptation, and the way that we can make that work economically, or in broader terms, including socially, of course, is to be able to communicate all of the benefits, which are the risks that the adaptation is managing. So we see a kind of a chronic undervaluation of adaptation happening because risk practice is not including all of these indirect kind of risks. So within the collaborative research, we've been building this system of systems representation. Also within the scope of the researchers, we've been identifying a series of indicative climate hazard vulnerabilities by sector. This includes things like flooding and wildfires, cyclones, landslides, and showing the magnitude and types of ways that these climate hazards can impact the system of systems. Similarly, and to address these climate vulnerabilities, we also have developed an indicative set of climate adaptation options, which can be used to address these vulnerabilities and points of weakness, everything from backup electricity generation and water, slope stabilization, increasing access through roads, and so on. The important point is that these indicative sets of vulnerabilities and options are to help the reader and to help decision makers kind of think through the problem. But of course, they are generalized and indicative, and it's important then in translating this to support any particular study, be that for a particular healthcare asset or a country. They need to be contextualized. Okay, so the next two slides, I'm going to highlight a couple of practical pieces of work that we've developed over the years that show how, well, this is not just theory, but we can apply this to support real decision making. This first example is a study that we developed in 2017 in Gaza in Palestine. Unfortunately, Gaza looks very different today compared to what it looked like then, but within this particular study, we modeled climate risk to every single building in Gaza, including all hospitals and healthcare centers, modeling the direct risk to them, but also the indirect risk due to failures in the electricity infrastructure. And those are the blue kind of network elements that you can see on the picture on the left-hand side. So we're able to get this direct and indirect risk profile to be able to prioritize for the country where network redundancies and local backups could be used in electricity to strengthen healthcare service provision within the country. Another example is a project we started last year and continues into this year. This one is with the World Bank and the government of Somalia, an exhaustive climate change risk assessment within Somalia, and with a focus on the transportation system, where here we modeled access of every person in the country to healthcare facilities with very sophisticated traffic models that include capacity of roads and health facilities and so on. So that with the flood risk analysis, we can understand healthcare access isolation, increased journey time by broken down by gender, age, and income throughout the country to be able to see who is most likely to be impacted in which locations, again, to support national adaptation planning. So the last slide here is just the conclusion. It's to say that we've really enjoyed and we're really enjoying this collaborative work with the GCA. We think it's really important. The main outcome of our part of the work is this description of the healthcare system of systems. We note of a small but increasing number of applied studies in this area, but yet we see a growing need for them and a growing demand that we hear from decision makers. We hope that this piece of research and this study can help to catalyze action, to help to take it to scale, and ultimately to support the development of more resilient healthcare systems worldwide. On that, I look forward to the discussion at the end of this session, but I'd like to hand over to Gerald for the next presentation. Thank you very much.
Thank you very much, Scott, for presenting this part. So my part that I'm presenting is connecting to what Edwina has presented already and Scott. So it's kind of building together, and I will be focusing on sustaining and improving access to healthcare in the context of climate change. So it is basically the same view that we apply, but from another angle. And so everything connects what Scott just looked at and what I will be presenting, and we triangulate the two different approaches to derive adaptation options that are applicable and that are also practicable. So what I'm highlighting here on the first slide is the approach that Scott had been presenting. So it's the healthcare systems of system approach, and it predominantly focuses on the supply side. And as we highlighted, or as we showed, we kind of integrate both approaches. We integrate an approach that looks at the supply side, that looks at the delivery of healthcare services, with the demand side. So looking at how people can access the healthcare services that are existing. This is from the viewpoint of the health system resilience. So if you look at health system resilience, it's a holistic approach. And if we follow the definition by Krug et al. 2017, health system resilience is the capacity of health actors, institutions, and populations to prepare for and effectively respond to crisis, maintain core functions when a crisis hit, and, informed by lessons learned during the crisis, reorganize if conditions require it. So it includes the supply side, which is health service delivery, and the demand side. And coming from the viewpoint that you've just seen here, that Scott presented, we look now at this red angle here at the bottom, where we build upon the integrated framework of health system resilience and climate change, which is a very recent framework developed by Ridde et al. 2025, so very recent. We build on that and we developed it further for this particular application of health system resilience in Africa. So as we already mentioned, so we have two co-authors who are not here, unfortunately, which is Valerie Ridde and also Manuela de Allegri. And they have been developing this integrated framework and helped us also to apply it to the specific context that we look at. What you see here at the bottom is that if we look at access to healthcare, so how can people access healthcare? There are two different types of dimensions. One is access dimensions, and one is the dimensions at the demand side. So we have two types of dimensions. And this is essential because if we assume that there are fully equipped and fully functional healthcare facilities, but there is no access, then it does not really lead to any change in health outcomes. So we need, if we want to have sustainable health systems, we need to make it possible that people access healthcare. So in the first place, I look at the supply side access dimensions, which are 5 here: approachability, acceptability, availability, affordability, and appropriateness. And this, some of you might know this conceptual approach. It's it's a very well-known approach by Levesque, 2013, that applied that. And this is now the way how we apply it to climate change adaptation. And then on the second slide, I will look at the demand side dimensions, which are ability to perceive, ability to seek, ability to reach, and ability to pay and ability to engage. And I will highlight only a few of them because we've only little time. So here you see the supply side, and I will pick a little information out of the supply side. So the first, which this integrative approach actually showed us, that health systems are highly dynamic. What does it mean? So basically, health systems always adapt to all kinds of changes in the environment, which includes climate change. So we need to assume that it's a continuous process of adapting. So health systems always adapt. There's never stopping in adaptation. And if we have now disruptive events, these events, like natural disasters, they lead to dynamic changes of the health system at the supply side and the demand side. So both the health facilities and the population adapts to the situation. And then we have a resilience process which goes through deterioration, collapse, recovery, improvement, through to the entire elements of resilience. So if we look now at the dimensions, which is the red box on the right side, dimensions that affect access to healthcare. I highlighted just a few of them. You have 5, which is from approachability to appropriateness. And I highlight approachability. So we looked at actually this dimension, which means that the population requiring healthcare can actually identify that some forms of services exist, can be reached, and have an impact on health. So this is what the definition of this dimension is. And looking at the situation of natural disasters and climate change, we identified that there's frequently the issue that the availability of health facilities and services during extreme weather events or natural disasters is not known to population. So there's a lack of information flows in these situations. What health facilities can deliver what, and where are they located? Are they actually functional? And can they provide the services we need? So this is kind of an adaptation approach, adaptation option that is required for people to access healthcare in cases of climate events. Then I would like to highlight the second one, or the third one here, availability and accommodation. This is very close to what Scott presented. So basically, and what Edwina pointed out, is that the healthcare facilities that are available can actually physically reached, and they can be reached in a timely manner. And this includes, for example, improvements in roads, improvements in infrastructure, also transport possibilities for population to the facility in times of disruptions, in times of climate disasters. So I would like just to highlight these two. And the report, of course, will holistically go through all the different dimensions. Now I jump from the supply side to the demand side, determinants of access to healthcare. So here is a lot of information on the slide, and I will focus only on the 2 red rectangles here. One is the immobility. So what is an issue in slow onset events, but also in natural disasters related to climate change? We find that many people are immobile. So there are some certain situations where people cannot remove themselves from the exposure to the climate event or to the disaster. So they stay in the dangerous area. And as well, they are not able to move to areas where healthcare facilities are available or to the health facility. So if we want to have resilient health systems, we need to make it sure that people are able to move, to be mobile, to actually visit the facility or to remove themselves from the dangerous area. So that's the part on the left side. Now we look again at the dimensions, which were drafted by Levesque 2013, which is the ability to perceive, to seek, to reach, to pay, and to engage, here on the right side. And again, I will pick only 2 of them. Or I focus on the ability to engage, which is an important one, because if we have situations of disruptions, if we have situations where the health system delivery is at a lower level, can it actually deliver all, or basically, can it deliver health services in the quantity and quality that people need? Then there needs to be something like a reduction, like a triage, and that certain cases of treatment need to be postponed and so forth. So if we have a situation like this, it's an ethical concern, and this is actually something where it really makes sense that the population is involved in the entire process of prioritizations and also in terms of the information, what needs to be reduced in these situations and what is the current situation during a disaster. So this requires actually, or these processes are required that the full extent of access to healthcare is enabled. And in our collaborative effort, in our collaborative research approach, we developed in total 13 adaptation insights and with a number of applicable recommendations. The recommendations are either tailored to national governments, to international development partners, and also to international financial institutions, and also climate adaptation funds that are available. Of course, we have very limited time, so I only focus on 3 main key recommendations. So these are actually not the recommendations themselves, but the categories. And it very much connects with what Edwina and Scott had presented. So the first one is deliver climate-proof physical healthcare assets to meet evolving and increasing healthcare needs and to prevent reduced capacity of health systems. So this is a situation where we need to know that in times of climate change, we have an increasing and also changing demand in healthcare. And at the same time, we might have temporary reduction in health system capacity. So we need to kind of align both of them, the reduction and also the increase and also changes in healthcare demand. As Scott pointed out, the interdependencies of the health system with supporting systems and also with other subsystems of the health system is essential so that the health service can actually be delivered. And then we already touched that we need to ensure physical accessibility of healthcare assets. The roads need to be there. Can it be flooded? There need to be alternative ways in case there's flooding, for example. Then that's the second one here, which is the third in the report. Think health system adaptation from the goal to sustain access to healthcare and consider the population as an actor in health system resilience. They provide the demand for health services. And if we have a functioning health system but no access by the population, then it doesn't change health outcomes. We said that already. So we need to ensure sustaining the demand and supply of healthcare. So both need to be sustained in order to have a resilient health system. And as Edwina pointed out, international standards and also national planning is essential to ensure that, because there are several sectors involved, from the electricity sector to the actual health sector, and we need to align the adaptation of all these sectors to have a functioning health system. Then the third one, which is here point 7, because it's point 7 in the report, provide the financial resources needed to make health systems climate resilient. This is essential because it is just at the point 0.5% of adaptation finance is made for the health system resilience. So it's a minor financing, and IPCC concluded that is absolutely insufficient to maintain health. So it's important to invest in health system resilience and human resources to sustain health systems, and to expand adaptation financing through climate-informed investment decisions, so that all investments related to health systems have some form of climate assessment and manufacture in the changes that are coming through to climate change. So thank you very much. This was the overview, and I hand over to Nidhi, who reflects on this and added a point on mental diseases as well. Nidhi, you're still muted and your camera cannot be seen. Thank you.
Hello, can you hear me?
Yes.
Yeah, very good.
Okay, so thanks again for giving an overview for this report. I'd like to also share some slides, but before that, I'd like to make some comments on the report. First, I think it's very impressive to see how with the diversified spectrum of the health outcomes. But I do see that there is still scope for broadening the mental health, psychosocial well-being, and psychological sides of health burdens related to climate shocks and disasters. That's point number one. And I think unpacking that in different priority subgroups or sub areas in terms of recommendations, in terms of acknowledgement, in terms of solutions, could also add value to the report. Another thing which we, from based on our own work in this nexus, um, we like to point is that there are very nuanced aspects of how mental health is manifested in different socioeconomic groups that would need more dedicated attention in terms of adaptation options, be it disabled people, indigenous communities that are directly linked to that coexist with nature, and these communities feel much more impacted by ecological degradation, or if climate-related climate-related crisis is impacting their surroundings. Point number three. Yes, I was quite impressed by this the socioeconomic complexity, how it was defined in terms of ability to engage. And I think this is like a very nice segue to position mental health, because with an ability to engage mental health burdens and discussions on how to mitigate those aspects like trauma, anxiety, depression that people feel in short, medium, and long term towards exposure to climate and disaster events can go a long way. And here we like to reflect that it's not always clinical interventions, it's mostly non-clinical interventions and community-led support that goes in terms of building resilience in long term. And point number four is explicit mention of mental health burdens, solutions wherever possible in different sections. And we see that the health discourse has really gained momentum in the climate domain, both at COPs, but in academic literature. And however, still mental health is only seen as a small mention, or sometimes pretty underrepresented. So we request all agencies, experts who are working on to generate data, information, and knowledge in this nexus to give more explicit mention of mental health and try to position it as a priority sub area within the health related recommendation. Because we do believe that on this underrepresentation, the cost of inaction will go pretty higher than the cost of action. And I think for a community to acknowledge mental health, oftentimes, especially in Global South, there are aspects of taboo and stigma, and this is still not really openly discussed in any sessions or documents. So these are five main comments, and I would like to congratulate and compliment your team to have brought this knowledge product for the benefit of scholars and practitioners and decision makers and development and financial agencies to take note of gaps and needs. And with that, if you allow, I'll also like to share some of the work that we are doing in this domain, just to give some more reflection on the African context, and through work in Ethiopia, Nigeria, and many other developing countries around the world. We have produced multiple reports, and I've just consolidated 4 or 5 bullet points to ensure that the message that we want to give is coming clear. Well, climate shocks are risk multipliers. We have heard that enough, but in this whole understanding of risk and health burdens, focus on anxiety, aspects like anxiety, depression, post-traumatic stress disorder, in case people or communities are exposed to disaster events that have had a direct impact on them, their family members, or their loved ones in any format, direct or indirectly. I think we have noted that really impacts them in the long term. And in some communities, it also has led to substance abuse and so I think these are trends that we have increasingly noted. There is quantitative data which I'm not going into, but I've noticed references for participants who are interested in taking a deep dive. Mental health impacts persist long. So this is something that we also wanted to emphasize, that though the health burdens, sometimes we see the physical health burdens can be mitigated, where there is sometimes waterborne disease after a flooding event. But in case of mental health solutions, it needs a more time spectrum approach. So a short-term intervention, medium and long-term, because the mental health conditions are such that they can persist for a long time, sometimes the whole lifetime of an individual, if they don't get necessary counseling, help, or discussion space. And this is really rising among youth, where limited support systems are available to support this need. Young people in particular feel very helpless and fear about climate future. And in one of our surveys, we noted that there is a sentiment of like the doom and gloom, and there are people who really don't want to even have children. So there are sort of extreme answers that we noted in some of our surveys. From an African context, we also got into understanding what amount of financial pledges are made to mental health, climate-related mental health burdens, and it's more or less less than 2% of the health budget that goes to mental health related support systems. And that really limits the preparedness of psychological stress and other category of mental health outcomes that communities and different spectrum of social economic groups feel. Another interesting thing that we noted is just not the community that is directly impacted, but it's also the responders. The first responders are the health workers that also are subjected to mental health and psychosocial stress, because they are also finding themselves in the same situation, the same scenario. So this is more of a, I would say, a double-edged situation which needs to be handled in terms of support systems which cater to both community but also the responders and the support system workers. So this again was more of a blind spot, that only communities subjected need help, but on a long time the health workers also need their set of counseling to be able to counsel and translate that understanding to the wider community. This need becomes even more relevant when there are situations of displacement or migration or people who have been forced to leave their habitat for a temporary or permanently, and they are in a situation with the access, and this was definitely mentioned multiple times in the interventions before. So our idea is to keep pushing for mental health integration into climate adaptation planning through existing protocols like national adaptation plans and other kind of commitments that countries or communities are making at their level. One thing which we feel is still pretty not really explored that much is reinstating the community health systems in terms of volunteers, in terms of non-clinical interventions. So for the case of mental health requirements, we can train non-specialist health workers. So this was one of our recommendations that we made also in the case of our case studies in Ethiopia, DR Congo, and Nigeria. And I see that these countries, in many countries in Global South as well as in Global North, they have their own local and indigenous knowledge systems. We noted that during our work in Canada that there is enough knowledge that they want to they really want to integrate into the modern knowledge plus integrated into indigenous knowledge goes a long way for the community buy-in. And cultural practices, faith-based care, community solidarity, these are things that have been explicitly noted after an episode of disaster, flooding, or any other kind of disaster, that the community has stood up for each other. And I think this culture of co-creating adaptation interventions or resilience planning can be a win-win, both for the government, for the policymakers, but also for the financial agencies funding this long-term scenarios of resilience planning. I think this is more conceptual and solution-oriented. However, the barriers are also to be discussed openly, and in many countries there is still a lot of stigma, culture, norms, or taboos to discuss mental health, whether it's a general mental health scenario or climate-related mental health scenario. And so most of our work is now understanding these stigmas and culture norms, and to use those sort of gateways through which we can still mobilize community, or these gateways to have an acknowledgement of the need of adaptation and resilience policies to incorporate mental health. The definition itself is very clear. So mental health and social well-being is a part of WHO definition, pointing to the multifaceted nature of health. However, in case of mental health unpacking, we need to take a long-term approach in terms of it's lifelong, right from childhood to adulthood, in how we feel, think, and act, how we're able to handle stress, relate to others. And these learnings or these interventions can start as early as school, primary school, secondary school, university, and a workplace. So in terms of interventions, we need to design solutions that can apply to each of these scenarios, each of these groups, and each of these places of learning. And another dimension that we are trying to now add into a conceptual model is the model of care, because mental health is an individual entity, but care could be a collective entity. It could be at the household level, community level. From an indigenous perspective, it could be much more defined, because there are practices, relationship, and responsibilities within a community that are very defined. There is for example, in the First Nation communities of Canada, there are clan mothers or grandmothers. These are, like, they call it clan mothers. So any young person who has got some kind of a distress related to why the lake is polluted, and there have been a notification that you can't fish, which is a cultural activity to go fishing when you turn 15. So can go and talk to these wise and elderly people in the community to be able to discuss that anxiety they feel about changes in their surroundings, or being subjected to a long-term climate crisis or disaster event. So these practices are somewhere more structured than in other cases. And I think this care component, if we add into, especially into the health related support systems, that can also be a value addition, and can also be a more of a co-creation exercise to designing health-related solutions. And I'll not read all of this. I'll just say that care can operate at scales, which I just said, but it's also contextual and political. However, though sometimes it can appear like a simple word, but in many cases, it's also shaped by power relations, inequalities, and cultural norms and government structures. So there are care centers. For example, we have children's care center in many countries. The care centers for mental health is not necessarily for pre-counseling. It's already post-counseling. So when you are diagnosed, you are counseled, not for a kind of a feeling of an anxiety, but after so from a medical viewpoint, the care facilities are pretty much unstructured across the spectrum. So these are, again, I don't want to go into detail, but we wanted to focus on also the care at dimension. So I think I'll leave it here, and I'm happy to answer any questions.
Excellent. Thank you so much, Nidhi. And good afternoon, everyone. I'm Katie Momber. I'm the Senior Programme Manager at the International Coalition for Sustainable Infrastructure, or ICSI for short. I'm delighted to moderate this short Q&A segment of the event. So I'm welcoming back all of the speakers. And thank you to audience members who have submitted your questions. Please do continue to add these as the conversation progresses. If we don't have time to answer them out loud, the panelists can also write answers to your questions as well. So in the interest of time, I'll just kick off with a question. So we've heard from both Scott and Gerald about how health systems resiliency really depends on their supporting systems. So a key challenge is often that these supporting systems belong to different state departments. Does any of the panel have an opinion or an insight into how this could be overcome and managed? Please feel free to unmute. Scott, I see you've unmuted. Please come in.
Yeah, thanks a lot, Katie. And I think the first thing is that you have to understand where these dependencies are, and that's something that we've been undertaking through this research. I think that's kind of the starting point. Then one needs to understand what are the levels of protection and the standards that exist within the different sectors. It might be that energy is really already taking adaptation seriously. They already have very high standards of protection, and so perhaps whilst it is something you need to think about, perhaps you don't need to be worried about it. So that second step is to think through what are the standards of protection, understand what activities are planned in each sector. But then, of course, one is likely to find gaps in areas that you do need to strengthen to enhance resilience of healthcare. And there, I think it's about there's a lot of dialogue and a lot of discussion. But this can perhaps address some of the financing topics around things like co-finance, because if you implement a particular measure, maybe it's a flood protection wall, that could perhaps protect some electricity customers. It could also protect some healthcare patients or services delivered from some centres. So I think there are opportunities with this kind of dialogue as well as challenges. But for sure, dialogue has to be a really important part of it.
Excellent.
May I add something?
Yes.
Yeah. Thanks, Scott. I think it's exactly this point. So if we look at different countries, we see that there are always sectoral strategies, but climate change adaptation requires an intersectoral thinking and cross-sectoral thinking. So this is something which is really challenging for many countries, because if we talk about health sector, then it's usually the Ministry of Health, but this is not far-reaching enough if we think about adapting the health sector. So there actually have been several possibilities developed. One is, of course, the national adaptation plans. So they are intersectoral, the NAPs, and also the so-called NAP implementation roadmaps is intersectoral. If you look at the health national adaptation plans, often this is under the Ministry of Health, so more sectoral. But also if you look, and this more and more needs to be integrated, the disaster risk management strategies, they're again intersectoral. So this is probably something how one can approach it. But of course, it needs to have a buy-in of the Ministry of Finance, which oversees the other departments, and also to interlink the different parts. And that's a big challenge.
Excellent, thank you. And we've started talking about finance here as well. So I might move on to ask you about the extent that health adaptation is funded, and if any of you have any thoughts on how to close this gap. I know, Scott, you talked about co-finance, but maybe GCA colleagues might want to come in around the financing of this.
I can directly come in and start the discussion. So if you read this, it's just 1,000 pages or 1,300 pages, I think, the IPCC document on adaptation from 2022. And if you read the parts which relate to the health system or health system financing, health system adaptation financing, it's really a disaster, because the IPCC concludes that at the moment only 0.5% of all dispersed multilateral climate finance projects are health sector projects. And they also conclude that it's absolutely insufficient to protect human health. and also health systems. So the funding currently, the level is way too little. It's disastrous, the situation that we currently have. There has for quite some years now, even before 2022, there has been a push, particularly in the African countries. There have been many different strategies developed. Also, the funding already has gone up to some extent, but it really requires international financing, international financial institutions to invest in the health sector, also to actually increase the priority in the country's budgets. That's also necessary. To also partner as far as it's possible with the private sector, because we always have to think about the counterfactual. So how costly is it if we don't do anything? And this is way more expensive than the adaptation efforts. So it really is a financial reason to adapt. And yeah, this is important, I think, to think. But this is also a way to go for many stakeholders.
Yes, thank you. That cost of inaction. Does anybody want to come in on the finance question? If not, I see we have another one in the chat in French, but I've translated it.
Yeah, I can add to Gerald's approach. So in Africa, the 0.5% has actually increased to 25% in 2024. So there has been increased momentum, and that was at the 77th World Health Organization Assembly, where they increased health finance in data research and early warning signs for the African continent.
Thank you. Thanks, Adrina. So we've had a question in the chat around how reoccurring climate crises, but combined with persistent security and humanitarian instability, affect the resilience of health systems and the well-being of vulnerable communities. They've mentioned specifically in Eastern DRC, but maybe you can talk more sort of widely on this. And they've asked around sort of coordinated responses that could be strengthened to limit impacts. So I suppose coupling that climate crisis with the humanitarian and security instability and the impacts of that and potential responses. Maybe Scott and then Nidhi, you could come in. But anyone really, feel free to unmute and come in on that.
Maybe I think I can comment from based on our work in DRC, Democratic Republic of Congo, and we were working on the climate, water, gender, migration nexus, and health was identified as like a subset. So there, first of all, there was no acknowledgement that at that time, 6 years ago, that health should be a part of the climate related discussions. And I think we have gone, of course, a few steps ahead in at acknowledgement. So that's a positive outcome of global discussions filtering to national and local. However, there is still gender disaggregated health burdens that need specific data, information, and knowledge to design or influence any kind of policy decisions. And we are not yet there in terms of having that accurate, accessible data and information. We know that water and sanitation is directly linked to physical health burdens, musculoskeletal outcomes, for example, one. And that would need a discussion that health and water stress agenda should be more intersectoral. However, in terms of mental health, first acknowledgement step is not yet even there, because when there is water crisis, it's the women of the household which are the purveyors of water bearing for water needs of the household members, and the stress that they feel in short, medium, and long term is not even acknowledged or diagnosed. So this really, without proper documentation, diagnostics, and reporting, I think we are very far from a gender balanced or a gender equitable policy in terms of health, designing health support systems related to climate and water stress scenarios.
Thank you so much, Nidhi. And then we're almost out of time, but Scott, did you have maybe a final comment on that before I wrap up?
Yeah, thanks. Just briefly, yeah, look, resources are scarce, and they're increasingly scarce in most countries around the world, and in particular in contexts in sub-Saharan Africa. And it's important that the solutions that we develop from a development perspective can address multiple topics. I think Nidhi's suggestion here and focus on water is an important one. The lack of water and water stress in the environment is a key driver of conflict. It can have negative health outcomes through the absence of water. It's a key determinant of poverty. I think there are, so that's just an example, but there are many other things besides that. Solutions that can have multiple outcomes and positive outcomes in the development sense. So I think thinking about those solutions is the best way to to target multiple stresses. Thanks.
Thank you so much, Scott, and thank you to all of our speakers, and also thank you to those who have asked questions. We greatly appreciate your participation. It's never enough time, an hour, but I think we've covered a lot of ground. Please all keep an eye on GCA website for our report launches and webinars, and we hope to see you all soon at the next webinar that GCA hosts. So thank you very much, and I hope you all have a lovely rest of your day. Goodbye.